Modified radical mastectomy is actually a gold standard surgery for carcinoma of the breast, and one surgery that every surgeon who has to treat breast cancer must know. In fact, I call it the workhouse of general surgery, and every surgeon who's trained in general surgery, who has to be made into a general surgeon, he should be aware of doing the modified radical mastectomy the correct way. Now, what is modified radical mastectomy? The term actually conventionally means removal of the breast along with axillary tail of Spence, along with an ellipse of skin with nipple areola complex, and the ellipse of skin has a margin of at least 1.5 to 2 centimeters from the lump that is the reason for doing the mastectomy. In addition to that, pectoral fascia, the level 1, level 2, level 3 lymph nodes, these are the structures that are removed, and the important structures that are preserved include axillary vein, nerve to serratus anterior, thoracodorsal nerve, which is a nerve to latissimus dorsi, and of course the muscle, that is pectoralis major. We try to preserve both major and minor in most cases, along with their nerve supply. The pectoralis major is preserved to provide contour to the breast, to the chest wall after surgery. And in the old radical mastectomy, this is one muscle that used to be removed, very disfiguring and not required at all now. Now, having said that, there are various understandings or the various ways to look at modified radical mastectomy, but I would like to highlight that it's one surgery which should be done correct way, and actually you may achieve between 25% 5-year survival rate by doing this surgery optimally and correctly. Therefore, there is a reason to have this model which can actually show some finer aspects of the modified radical mastectomy, and it will be followed by one of my many videos on modified radical mastectomy that are live, so one can actually connect to both and they can complement each other in the training of a resident and also surgeons into how it should be done. The disclaimer is this is not the only way to do it, and certainly is just one way of doing it correctly, and we'll try and explain each step as they happen. Importantly, when you're making an incision, you must make sure that you mark it. Most incisions for mastectomy should ideally be placed transversely, and they should be lateral to the lateral edge of the sternum, because if you cross over, you are on the sternum, which can actually go to the other side, and then there can be a possibility that the other side may need to be irradiated in that process, which is not acceptable. And the lateral limit should not cross the anterior axillary fold, because the rest can be achieved through this incision, because if you extend this transverse incision into the axilla, you're actually exposing axilla also to, it will be, the scar would reach there and scar becomes a part of the zone of radiation. So therefore, I would once again repeat, most incisions are transverse. They can be oblique once in a while, but by and large that concept is gone. In spite of the oncoplastic breast surgery which has come big time, the incision should ideally be transverse, and it should be extending from lateral edge of the sternum to the anterior axillary fold or the anterior axillary line. That's about the transverse axis. How far should we go above? There is something called as the footprint of the breast. The footprint of the breast is extending to about second rib and below to the inframammary fold. Now, we can mark it and actually try and achieve the extent of the flap to that level. Having said that, it's not mandatory to go that far if the breast is small. So it will actually vary and it is subjective. The classical position for the patient is a little thin sandbag under the ipsilateral scapula, which is to push the posterior wall of the axilla anteriorly so that the axillary dissection becomes convenient and easy. We normally keep the arm and the forearm separately draped so that we can adduct it when we are trying to do the level 3 dissection, which actually relaxes the muscle that is pectoralis major. We never cut the pectoralis minor but I am aware of the fact, and I often teach my residents, never say never. The old patty mastectomy, but still which a lot of people practice, involves cutting the pectoralis minor in order to reach level 3. But it is possible to reach level 3 with a sling. I'll try and demonstrate the same thing in this model and also in the video which is live that will follow the demonstration on the model. Now, a word about how this simulator could be created. Well, it involved a lot of thinking and a lot of hard work, and I would like to acknowledge the role of my postgraduate, very dear student who's worked very hard to make it happen. And we will make sure that more such models come into use, and we basically want to use it for training of residents, and as I say, for sharing the information and also the ignorance. Now, one can see that the transverse axis has already been marked. This is sternal edge, and that's the anterior axillary fold, which is what actually I was talking about, and that's the latissimus dorsi, which is my lateral limit of actually the mastectomy and axillary dissection. But that doesn't mean you take the incision in the skin to that far. The incision is being marked, and as you can see, we have got the lump marked first, and then we take 2 centimeters margin away from the lump, and then we have this ellipse done, and that's the nipple areola complex, and the margin is reasonably good. Make sure a mastectomy, when you're doing it, should be the conventional mastectomy. Modifications are individual. That's the areola and that's the lump. Well, I can understand, and we have a lot of videos to share that one can do oncoplastic breast surgery, but naturally breast conservation involves a separate set of indications. That's the incision marked, and now the incision is being made. Almost invariably we would be using 50 number blade, but here, to make it easier and to be able to demonstrate, we will be touching just the salient points. Kindly bear with us. It is almost impossible to create a normal human breast, but an attempt has been made. It is basically to highlight some important points, and one should not get distracted by events happening around. Now, this is the incision which has been made, and then incision is deepened in the skin, and then most of the time our approach is medial to lateral, and then we try and raise the superior and the inferior flap. The superior flap is conventionally what we raise up first. How thick is the thick flap, how thin is the thin flap, is what we'll try and show here. We don't rely on of course there are various theories. One is small breast lobules, fat lobules are subcutaneous, and the larger ones belong to the breast. But in a fat individual it may be difficult, so we rely on a dermal plexus, and we have actually published our data on this, and we use dermal plexus as a routine to lift it up, and we have gone down to the pectoral fascia, then we lift it up medial to lateral. Some steps have been done to just demonstrate the procedure correctly, and now you can see that the perforators on the medial side, usually they are clipped or ligated or they are diathermized. They can be 2 to 3. They come from the internal memory artery, and they are the perforators that one uses also for the deltopectoral flap. So these are medial perforators, and this is the dermal plexus which we rely on in most cases, and then we don't really bother about the thickness, because if the plexus is on the flap, we are sure about its blood supply, and that's what we are looking for. The fascia is then taken along with the breast tissue. The rest is more or less very routine, and I'm sure a lot of you are very familiar with those steps. But just to highlight, we deepen the incision down to the pectoralis fascia, which is lifted along with the specimen. We try to go medial to lateral because it's easier to start medially, and that's pectoralis major in view, which is sharp and glaring. As you can see, the fibers going towards the humerus and clavicle. We take the fascia off, and it can be done very safely. There are few perforators that come from the depth. Breast is supplied by perforators from all around. The lateral extent, then therefore we extend right up to the lateral edge or lateral border of pectoralis major, where we will encounter the clavipectoral fascia, the fascia that needs to be cut. Pectoral fascia in the lower part and clavipectoral in the upper part, and one can now once again appreciate the anatomy. These are the perforators. Pectoral fascia has been taken along with the specimen, and we go laterally. Now this is one step which is very important. We adduct the arm at this point. We then try to retract the pec major, and what you are seeing right now in front of you is actually the pectoral pedicle. The medial is lateral and lateral is medial. Both these nerves must be preserved. Along with that, you can also see the pectoral branch of the thoracoacromial artery, which is actually also an artery for the PMMC flap. Now, this is a rotus group of nodes. We have got pectoralis minor below, which is greenish here, and pectoralis major above. We gently tease off the rotus group of nodes with a forceps counter traction and a right angle mixture. Now, what comes into view is the the lateral pectoral nerve, which is medial. The nerve, the medial and lateral is essentially based on the cord from which they come. Now, the entire tissue on the superficial aspect of pectoralis minor, that's a node, as you can see, the shining thing here, that has been demonstrated as a node, and we do find rotus nodes positive, which are part of level 2 incidentally. Now, rotus group of nodes or interpectoral group of nodes are all peeled off gently. One can use a diathermy, cold scissors, or right angle mixture as I am using here. And then we try to go as far as the medial border of the pectoralis minor, and we never cut pectoralis minor. Repeat, we don't cut ever, and actually you can easily retract it, which is the next step. So what do? We go under the surface and you make sure that you don't take the pectoral nerve in your grip. At least one of these pectoral nerves must be preserved, and you can see it more clearly. There's some more tissue, which is fibrofatty tissue, along with the nodes, that needs to be cleared because they are very minor lymphatics, the lymphatic tissue which needs to come along. Now, I am once again reminding you the assistant has adducted the arm and the pec major is retracted, and now we are trying to take the pectoralis minor on a sling. Almost invariably, we do that using an infant feeding tube. It's important to negotiate the tube below the pectoral pedicle, otherwise you are likely to injure the nerve or the vessel, and that can cause bleeding. Avoidable, and at the same time pectoralis major and its nerve supply and blood supply should be kept intact, and in future also for the PMMC flap. Now, the assistant would retract the pectoralis major laterally, the other hand would retract the pectoralis major medially, and that will expose level 3. As a routine, we do level 3 first. The medial limit of level 3 dissection is Halsted ligament, which will soon be visible. Now, there are the nodes, as you can see, and we try to gently tear off, rather I would use the word tear off, peel off, and it continues to come down. Make sure you don't peel off the sheath. That's the supreme thoracic artery and also the vein, and you can see the axillary artery and axillary vein both being visible. Axillary vein is down and below and medial. You can see that due to retraction it may sometimes be that the artery seems to come down, especially in level 3 area, and one should be careful that one doesn't damage it. It's deliberately demonstrated that way because otherwise you'll see right through the course the axillary vein is the one that presents first. That's level 3, and you can see the Halsted ligament medially. Once that is done, I'm going to point towards Halsted ligament very soon. We generally take a wet gauze piece and tunnel it under the pectoralis minor to take the level 3 down to level 2. The lateral limit of level 2 is lateral thoracic vessel, which is lateral thoracic vein and artery. So once the pec minor is lifted laterally, it will be impossible to just rely on the medial and lateral border. Therefore, these anatomical endpoints are important. One can see nicely the intercostobrachial nerve coming into view, and this is the lateral thoracic vein, and that's the lateral thoracic artery, which are the branches from the second part of axillary artery. The first one I've already shown you, thoracoacromial, the branch of which was pectoral branch, which you saw going towards the pectoralis major. And you can see it very clearly now. This step is to just demonstrate that you may or may not ligate the lateral thoracic vein and the artery, or you can spare them. But here I'm just demonstrating that it's convenient to ligate and peel down the lymphatics. It's a very useful vessel for the lateral flaps. A lot of people use it for LICAP. So it is not always that you need to cut it. This is just to demonstrate a conventional step. I've ligated and diathermized the other end, and then you can see the nerve to serratus anterior now coming into view, which is very clearly seen going down along the chest wall. Never go looking for these structures, they come in your way as you go down. Now axillary vein is clearly visible, and as I said, beyond the lateral thoracic it is level 1. And you can see that axillary vein is the only vein structure presenting now. You cannot see the axillary artery now. I just demonstrated that in level 3 so that one is careful. Now, there is no reason to go superior to axillary vein. Most of the dissection should stay inferior and below, and we should not peel away the sheath. You can see lots of lymph nodes being dragged down along with the fibrofatty tissue, and the intercostal-brachial nerves are 3 to 4 in number. It is the superior most which we tend to preserve, because that actually also is important for preserving the sensation along the medial side of the arm. And there is one above this also which we can sometimes preserve, which will be actually an indicator of lymphatics that are draining. The lymph nodes that are draining the arm are usually above the superiormost intercostal brachial nerve. Now, one can actually drag the lymph nodes with traction and counter traction. It is possible. I can't be showing you diathermy here naturally for obvious reasons. The idea is to just demonstrate the surgical anatomy, axillary vein above, lateral, the nerve to serratus anterior on the medial side, and now you can see in the depth the thoracodorsal pedicle is clearly visible, and that's the Letzmann's dorsi muscle, the surface of which is being bared, and you can see the subscapularis in the floor, and you can see the thoracodorsal pedicle, which is artery, vein and nerve. It is lying over subscapularis. We generally take it on a glove sling, which is a protocol that we follow in my unit. It is stretchable, causes less neuropraxia, and we use and we particularly train residents into handling this pedicle carefully, because this is one pedicle that is very useful in reconstruction, and it is used for Letzmann's dorsi flap. The rest is simple. There is a counter traction now because of the glove sling, and the lymphatics are now being dragged down, gently peeled off. It's a mixture of cold knife and diathermy. You can use any energy source, and this is a lymph node which looks significant, larger than the others and shining. The thoracodorsal artery, but subscapular vein, which is formed by the junction of angular vein and thoracodorsal vein. So it's just below the angular vein that it's thoracodorsal vein, otherwise it's subscapular vein, and that is the angular vein, which is a vein that comes from the chest wall to join the thoracodorsal vein to form the subscapular vein. And that angular vein, it is our own publication, forms the lower limit of axillary dissection. That's the thoracodorsal nerve, that's the thoracodorsal artery, that's a subscapular vein, which is actually formed by the junction of angular vein, which is coming from the chest wall, and thoracodorsal vein. That's the intercostal brachial nerve, and the subscapular is visible in the floor. That's axillary vein. You can see that artery is actually above the vein. So if you're actually able to see the pulsations, you've gone too far high. So this is one way to understand it. That's why it was very clearly demonstrated for this purpose. The vein will be going up because the arm is adducted. Now you can see the serratus anterior muscle clearly, the digitations are visible, and we've traced this nerve right down to, and please don't cut the intercostal brachial nerve unless it is directly getting into the tumor, that is into the lymph nodes, and always see the nerve to serratus anterior before you cut it. You will see it in my live video also. Now that's the pectoralis minor once again shown. The Halsted ligament would be once again visible, that's golden and shining. As you can see, that's the medial most limit of axillary dissection. That's the Halsted ligament. And the supreme thoracic artery and vein are visible, and that is the first rib. Some people take that as a landmark. It's perfectly fine. I have deliberately put axillary artery a little in front, although it is also above and you generally see the vein. But this is just to let you know, sometimes the artery could be presenting just before the vein and you should not damage it. This is all level 3, and you can see that level 3 dissection is nearly complete. That's the lateral thoracic vein, which is considered to have been ligated. That's the artery and the vein, that's the nerve to serratus anterior, and that's the intercostal brachial nerve, the axillary vein, the subscapularis muscle is in the floor, then you have the thoracodorsal pedicle, that's the thoracodorsal pedicle, clearly visible. We trace it right down to the angular vein. So I'll repeat: medially Halsted ligament, superiorly axillary vein, laterally Letzmann's dorsi, and the thoracodorsal pedicle, and below it is angular vein. As I mentioned, our own publication to show that that we use this as a landmark, which is more reliable than entry of the nerve to Leschmann's dorsal into the Leschmann. That is subscapularis, and that completes the axillary dissection.
Now, the patient is usually kept in a supine position, and you can see there is a small sandbag under the right shoulder, right-sided breast lesion. And we have marked the incision, which is with a margin of about 2 centimeters of skin. Now, this incision is then deepened all around. It's an ellipse actually, which encompasses the nipple areolar complex and also a bit of skin, which is also controversial because a lot of people do preserve skin these days in doing what is called skin sparing mastectomy. Now the flaps are raised. The superior flap is usually raised first, although it is optional. And when you're raising the flap, it is to go up to the clavicle superiorly and inframammary fold inferiorly. And as you can see here, the pectoral fascia is being lifted. Bowie or cold knife both can be used. And actually, you can see a plexus of veins here, which is what we use as a guideline to see the thickness of flap, because often there is a controversy regarding how thick, how thin, how thick is thick flap, how thin is thin flap. So this is the best guide. And we are lifting of the pectoral fascia, which should be raised each time that you're raising the specimen. And you can see in between that pectoralis major muscle is clearly visible, and that's a ligament of Cooper, as you can see the white structure there. Now, as you're lifting the specimen, it's preferable to go from medial to lateral side, and you will encounter minimal bleeding if you're in the right plane. I use diathermy mostly, and lots of surgeons prefer to use diathermy, but it is entirely individual choice. There's no difference in the outcome. The bleeding is less. That's the only advantage. The aim is to go medial to lateral in the lateral border of pectoralis major, lifting up the entire specimen superiorly and inferiorly. Now this step shows our entry into the axilla, where the pectoralis major has been lifted up in a detractor and pec minor is lifted up on a sling made of a feeding tube or any sling that one can use. And now this is level 3 dissection, which is dissecting the lymph nodes that are lying medial to the pectoralis minor. Now this step is often neglected, and we leave behind some lymphatic tissue there. However, having said that, most people feel that level 3 is not commonly involved if level 1 is free, but we do it as a routine since our burden of tumors would be higher than what we encounter in the West. So it's preferable to at least learn to do it correctly. And in teaching institutions, the dissection at level 3 should be purely shown. That's axillary vein, and you can see the medial border of this dissection is Halsted ligament. And we keep peeling off the tissue gently with a right angle mixture. One can use cold scissors also. The vein is clearly visible. That's the medial most part of the dissection. The medial border of axillary lymph node dissection is Halsted ligament. The lateral is thoracodorsal pedicle. The superior limit is axillary vein. Now, after you've cleared the level 3, we use a little gauze piece which is wet to tunnel the level 3 under the pec minor. We don't cut pectoralis minor these days. And Auchincloss method is the one that most people follow. Petties is not used, and we preserve both the pectoralis major and pectoralis minor and their nerve supply, which is medial and lateral pectoral nerve. You can see that gauze piece has been delivered, and with that, the level 3 comes down, and you can actually see the whole vein through the pec minor, the space under the pec minor. We already removed the interpectoral group of nodes, which is called Rota's nodes, and you can see that pec minor is free to be lifted up easily. And if that's a trick to do this dissection better, because if you have pec minor lifted on a sling and if you can cleanly dissect underneath, then the dissection is bloodless and you don't leave behind any lymphatic tissue. And that's level 2 dissection right under the pectoralis minor. We keep going laterally until we reach lateral thoracic vessels, and one could see a glimpse of nerve to serratus anterior, which we'll see again. I'll describe it later. Now that's lateral thoracic vessel, which according to the anatomical endpoint, that will be a lateral limit of level 2. It's important to lift it, dissect it, ligate it. I always like to tie it proximally, and distally one can diathermize it. But personally, I've observed the seroma rates drop if you ligate these, because lymphatic leak is a cause of seromas later on. But it's absolutely independent of my views. One can go the way he likes to do it and the way he's trained. And as you go laterally, you find the thoracodorsal pedicle emerging, which has got all the three structures. That's the thoracodorsal nerve, thoracodorsal artery, and thoracodorsal vein. It is good to lift it on a sling, which is stretchable, as this would reduce the incidence of neuroprexic injuries or neuroprexia of the nerve. In this pedicle, I teach my residents to dissect all the time. It also exposes them to the raising of Lexman's dorsi flap, which is very often used in reconstruction. And this is the level 1 dissection. So level 1 is lateral to pectoralis minor, level 2 is behind the pectoralis minor, and level 3 is medial to the medial border of pectoralis minor. And we keep going down along the thoracodorsal pedicle, and one encounters the intercostal brachial nerves. If they're getting into the specimen, they must be sacrificed, and when they are cut, it is preferable to use cold scissors rather than diathermy. You can see the nerve to cold scissors because there is a high incidence of neuromas with diathermy. So I personally use cold scissors. That's nerve to serratus anterior. I would like to mention here that once you've seen nerve to serratus anterior, that's the only time you should cut intercostal brachial nerves. But if you can preserve, it is advisable. But if you cannot preserve, and if they're getting into the tumor, it's better to sacrifice them, because hypoesthesia is better than hyperesthesia. The hypoesthesia on the medial side of the arm is what happens. You keep dissecting below, and you keep going down along the pedicle to find what is called an angular vein. In our own publication, we have demonstrated that angular vein is a very useful and a fixed, reliable landmark at the lower end. So the superior border is axillary vein, medial border is Halsted ligament, and the lower border is angular vein. And what you would see in the floor would be subscapularis. The lateral border would be, lateral limit would be Lexman's dorsi muscle. And that subscapularis coming up in the floor. And you can see the pedicle lifted up allows us to dissect all around it for lymphovascular tissue. It's fibrolymphatic tissue, all should come down, because if you're doing axillary dissection and if you leave behind lymphatics, that's not acceptable. Now, this goes down, and we are going along the pedicle. And as we keep going, we reach the lower border, and we are almost done with the dissection. But very often, having mentioned the lateral limit, we find nodes lateral to the thoracodorsal pedicle also. And that can be, once you spot a node, it has to be dissected. Now, all these structures can be once again seen. That's a thoracodorsal pedicle lifted on a sling. You can see the angular vein below, which would ensure that we have got, which of these endpoints actually ensure that our clearance is adequate. And you can see the nerve to serratus anterior is here. And you can actually go along, this goes along the chest wall. The floor is also clear. That's the axillary vein. And you can see that the entire, this triangular space is cleared of lymphatics. That's the lateral limit, Lexman's dorsi muscle, where the nerve to Lexman's dorsi can be seen entering. Now, very often people want to see in the workshops Halsted ligament. That's the Halsted ligament, which is the other name for costoclavicular ligament. And if you observe, the dissection can be very easily done after having cleared level 3, lifting up the pec minor, tunneling under that, level 2, and finally you can come down to level 3 and level 1. And we use rubber sling for a very specific purpose, because it allows us to clear all around the pedicle, and at the same time, there is minimal or no neuroprexic injury. Now, one would also be very happy to see that both medial and lateral pectoral nerves are preserved. Medial is lateral and lateral is medial in location. They're called so because of the roots of the plexus that they come from. And it is important to identify them and preserve them. There's no point preserving the muscle and not preserving the nerves. These are the medial and lateral pectoral nerve, and you can see the pectoral pedicle. Also the pectoral branch of thoracoacromial artery, which is going into the pectoralis major muscle.